So let's move on to the resuscitation portion of this. So oxygenation is the first thing I cover when I'm thinking about my checklist, getting that safe apnea time, getting nitrogen washout and get those sats up. And then I really focus on hemodynamics and resuscitation because we know that hypotension definitely can kill people when we intubate them. So let's talk about some predictors of hemodynamic collapse. Which patients in the pre-hospital setting have the likelihood of having post-intubation hypotension and post-intubation cardiac arrest. So until recently, most of the literature on this was in hospital. And what we saw was about 2 to 5% of emergent intubations. So again, we're not talking OR patients here. We're talking physiologically sick patients in the ER and the ICU. About 2 to 5% of them experience a peri-intubation cardiac arrest rate. So that's what we're seeing in hospital. And on the in-hospital data, the predictors for this are sort of this like 3 nines is a way to remember it. One, if you had pre-intubation hypotension, so a systolic less than 90 or even a less than 100 in some studies predicted peri-intubation cardiac arrest or severe hypotension after intubation. So intubating a patient who's hypotensive without fixing the hypotension is a really good way to kill people. Next is pre-intubation hypoxia. So we know those rates are fairly high. We've talked about ways to mitigate that. But just know if you're in a situation where you're forced to intubate someone who's still hypoxic, their rates of cardiac arrest are going to go up. And then the last one is a little less intuitive, but a pre-intubation shock index. So a blood pressure less than 90 or a SAT less than 90 is going to catch your eye, right? If you're looking at the monitor, those things are going to stick out. Probably your monitor is going to alarm at you. But shock index is a little bit sneaky. So shock index is essentially taking the systolic blood pressure, dividing it by the heart rate. So I don't actually do the math here. I just say, hey, if your heart rate is faster or higher than your systolic blood pressure, that is a high shock index, and that is not good. So imagine someone with a blood pressure of 120 over 80. Oh, that's a great blood pressure. Well, if their heart rate is 130 because they're in compensatory shock, that patient is still really sick, and that's a predictor that they may have cardiac arrest. So keep an eye on that shock index, and those tachycardic patients, really focus on resuscitating them as well. So this is in-hospital data. What do we have for the pre-hospital setting? So 2022, this trial came out, and it was observational data and was looking at a big cohort of cardiac arrest patients in the pre-hospital setting, or rather, it was looking at a big cohort of RSI patients who experienced cardiac arrest. So PICA or peri-intubation cardiac arrest. A few factors that stuck out here, increased weight. So patients who had a BMI over 30, this circles back to the incidence of hypoxia as well. Knowing that these large patients are at high risk for hypoxia, they're also at high risk for cardiac arrest. Pre-intubation hypoxia, so that makes sense, right? But then also anatomic difficulties. So if it takes you longer to get the tube because you're struggling with some anatomic difficult airway features, it's more likely that the patient will become hypoxic and then have a hemodynamic collapse. And then anyone who experiences a post-intubation hypotension or hypoxia is someone who's warning you they're going to die. So if you run that blood pressure right after you confirm your tube placement and you're getting that SAT, you're waiting for that SAT to come, back up with that little bit of lag time that it has. Keep in mind, be aggressive resuscitating these patients, both from a hypoxia and a hypotension standpoint. So this is a great time to start your vasopressors or give push dose pressors when you see that low blood pressure that pops up after an intubation. This last one was Sucks versus Rock, and they actually saw more hemodynamic collapse with Rock in this study. So I think that this is an outlier, and I'll tell you why. For starters, this study was done from 2014 to 2018, although it wasn't published to 2022. So in that time frame, we were definitely giving a lot lower doses of rock than we do now. And we know that the lower doses of rock take a longer time to get the patient fully paralyzed. So if we're giving a low dose of rock and then we're going in to intubate a patient without waiting for their jaw to be, flaccid and like airway reflexes to be gone, then it's less likely we'll get the tube. It's going to create an anatomic difficult airway. So again, in an observational data set, the science is not perfect here, but I definitely would not take this and say, oh, rock's terrible, never use rock. I think the take home is give a high dose of rock, make sure that the person is paralyzed, and then go to intubate them. So if we're giving the rock at the new like 1.5 per kilo dose that we've seen in the literature, then the onset is just about the same as sucks. So we have a shorter safe apnea time with that. Food for thought. Those are the patients who are going to be a little bit risky. So our big take home is not that we can't intubate these people, but really we need to focus on resuscitate before we intubate. So what this looks like, I think starting fluids is a good move, especially in a patient who we think will be fluid responsive. As long as there's no contraindications, I'm hanging a liter at least and flooding that in. Although the data has not shown that fluids alone reduce the incidence of post-intubation hypotension. So if someone still has a soft blood pressure, I'm more likely to get those pressors started early. So if they're hanging around 90 or 100, I'm going to hang my pressor. I'm going to pick norepi 9 times out of 10. To get that blood pressure up before I induce them. Now, push dose epi is a really great way to go as well. But if you're using push dose before your intubation, just remember it's going to be worn off about the time they're intubated and you start positive pressure. So if I give push dose, I follow it with an infusion. Or if I have a patient with a good blood pressure, I'm not starting pressors on, having the push dose drawn up and ready to anticipate that post-intubation hypotension can be really helpful. So mixing that cardiac epi, diluting it down with 9 cc's in a flush gives you that nice dose of basically you're getting 10 mics for every cc that you push. So that's really nice to have on hand for your post-intubation period.